the SB 1004 Technical Assistance Series. Today's webinar is one in that series. We'll be talking about estimating the number of individuals eligible for SB 1004 palliative care and appreciating baseline utilization patterns and costs towards the end of life. A couple of housekeeping items to take care of. One is that the webinar is being recorded. Copies of the slides and a link to the webinar recording will be posted on the CHCF website by the end of the week on the SB 1004 Implementation Resources page. The URL for that is listed on the last slide that I'll be presenting today. It's pretty easy to find also. You just go into the CHCF site and put in SB 1004. We'll also be emailing the slides to everybody who registered for today's webinar. Right now, everybody's in mute mode. If you have a question, you can type it into the question or chat box, and we'll address those questions after the presentation, or after the presentation, we'll let you know that when you can raise your hand and we can unmute your line so you can ask a question yourself. So without further ado, let's get into the content of this very interesting topic. Next slide, please. So as a reminder, the topics that we're going to be covering, these building blocks for implementing community-based palliative care as part of this technical assistance series to get people prepared to implement SB 1004. Today we'll be covering topic 1, which is estimating, how many folks would likely qualify for the type of palliative care that's described in the SB 1004 policy statement and legislation. So really, this is a topic that's of most interest to the Medi-Cal managed care plans, health systems, networks, and medical groups that have responsibility for creating the capacity to make sure that patients have access to this type of care. Topic 2, we'll get into estimating the costs of delivering services. And this is a topic that's really aimed towards the providers that are hoping to offer this type of care to the eligible patients. That topic, we'll start tackling that in a couple months. Topic 3 is evaluating current capacity for palliative care. So in a given region or within a given network, how much current palliative care capacity exists, and what are the prerequisites that both primary and specialist providers need in order to deliver this type of care. Topic 4, we'll be developing a strategy to expand services. So if there happens to be a gap between your estimate of the number of patients who might need palliative care and what you've assessed to be your current capacity, how do you go about bridging that gap? And what are some strategies that you can employ to expand the amount of service that you're able to provide? And then topic 5 is gauging and promoting sustainability and success. So we'll talk about best practices and sustaining partnerships and metrics and quality improvement projects and all of those things that you need to do to keep a successful program going. And just as a reminder, the webinar slides and recording will be distributed at the end of the week. Next slide, please. So the objectives for today's session is, 1, to appreciate why estimating the number of eligible patients or members, the number of folks who would be eligible for SB 1004 palliative care and how they're currently using healthcare services, why that's useful. And also to acknowledge that it's potentially difficult as well. We'll describe a prospective method for estimating the number of patients and members who might qualify for SB 1004. We'll describe a retrospective method for estimating the number of eligible patients and members, and one that also allows you to appreciate baseline utilization patterns. We'll then review some findings, just a handful of findings from a recent retrospective analysis that we were able to do in partnership with the folks at the San Francisco Health Network. And then we'll talk a little bit about the content and logistics for the upcoming in-person workshops on this topic. So today's webinar is intended to be kind of a high-level overview of this topic to give you an idea of what the main concepts are. The in-person workshops, which follow in August, are 3.5 hours long and will give us a chance to dive a little more deeply into these topics. Next slide, please. So first of all, why these data are useful. It is not an effortless endeavor to gather information about how many patients might qualify for SB 1004 palliative care. So why would you bother? Well, that type of data can really be useful in program planning and in network building for specialty palliative care. It's a little hard to figure out how many providers you need to contract with or how much service your system needs to be able to deliver if you're not really sure if you're talking about a couple dozen patients or a couple hundred patients. It also gives you an opportunity to appreciate how and when patients are accessing healthcare services currently. So it can inform estimates of how long will these patients be receiving palliative care and what types of opportunities there are to modify their current utilization patterns. It can also give you a leg up on figuring out where you want to focus education and outreach efforts to make sure that patients who qualify and would benefit from palliative care actually are referred to the service, places where you might do some educational and outreach work with referring providers so that they can offer more primary palliative care, and where you might want to focus some of your specialty palliative care services. This is also a really good preparatory step for analyzing the impact of palliative care service once they become implemented. So it kind of gets you on the road to seeing how many folks are there, how have they been currently using healthcare resources prior to broader availability of palliative care, and how did things change once we were able to start offering that service to patients who would benefit from it. And I just want to make a note that we will not be covering today a related and very interesting, but really a distinct and different issue, which is using claims data to promote appropriate referrals. I noted in some of the survey responses that you all submitted that this was a topic that people were interested in, and some, I think, thought that it would be covered in this particular webinar and in topic 1. That's actually something that we'll be covering in topic 4. So we recognize the importance of that. It's just a different issue, and we won't be talking about it today. Next slide, please. So the data, I am really convinced, having seen multiple programs work through the process of developing new or expanding palliative care services, it's really, really useful to gather data. But it is also a little hard to do, and there's a lot of reasons for that. For SB 1004 defined palliative care in particular, not all of the eligibility criteria that are part of the program can be assessed using claims data. In addition, even for items that you can generally get at by mining claims data, the diagnosis and other information that you have in your system could be incomplete or inaccurate, which kind of makes your estimates a little bit skewed. For some of the analyses, so if you want to do a retrospective assessment to estimate the number of potentially eligible patients, you have to go out and get some new data. You have to go out and get some data describing date of death for a population so that you can match that up with your internal data to generate some useful metrics, and that can be kind of you know, a slog to do. Oftentimes, folks also have limited IT resources, so your plan may not have analytic software that can be used to risk stratify patients or determine the risk for hospitalization or death, or you might just have a very non-nimble system, and it can just be generally tough to extract the claims data from some systems. And then also there's almost always the issue of limited analytic staff time. I think in many of your organizations, you have incredibly talented people serving in analytic roles, but they are just pressed to the limit, and making time for one more analysis can be kind of tough. So we acknowledge that. We know that it's very useful. We know that it takes an investment of resources, and it can be tough. But at the end of the day, I think it's a big net benefit. So because what we're doing primarily here today is trying to estimate the number of potentially eligible patients, it seemed like it'd be a really good idea to begin by reviewing the eligibility criteria. Next slide, please. So there's general criteria and disease-specific criteria, and as you read through these, you know, sort of think about, wow, how would I get at that? As you think about the criteria that have been incorporated into the policy. So general criteria, likely to or has started to use the hospital or emergency department as a means to manage his or her late-stage illness. Late-stage illness, appropriate documentation of continued decline in health status, not eligible for or declined hospice enrollment. Death within a year would not be unexpected based on clinical status. And I just want to remind you all that on the website that's maintained by the Department of Healthcare Services that's dedicated to SB 1004, you can download a policy paper that has the most recent description of the draft eligibility criteria. My most recent information is that these are not absolutely finalized yet, but you can get the most recent information by going to the department's website. Next slide, please. So additional general criteria: has received appropriate patient-desired medical therapy, or patient-desired medical therapy is no longer effective. The person is not in reversible acute decompensation. The beneficiary, and if applicable, the patient and family members agree to attempt in-home residential-based or outpatient disease management instead of first going to the emergency department, and they agree to participate in advanced care planning discussions. Next slide, please. So in addition to all those general criteria that apply to everyone who would be looking to take advantage of SB 1004 palliative care, there are also disease-specific criteria for the 4 diseases that are designated as being eligible in the policy. So the first is congestive heart failure. One is that the individual has been hospitalized with a primary diagnosis of CHF, and that no further invasive interventions are planned, or that the individual meets criteria for New York Heart Association heart failure class 3 or higher, and that person has an ejection fraction of less than 30% for systolic failure, or they have significant comorbidities. For COPD, the disease-specific criteria are an FEV1 of less than 35% predicted, accompanied by a 24-hour O2 requirement of less than 3 liters per minute, or just a 24-hour O2 requirement of greater than 3 liters per minute. Next slide, please. Disease-specific criteria for advanced cancer, so stage 3 or 4 for solid organ cancer, lymphoma or leukemia, and a Karnofsky Performance Scale score of less than 70, or failure of 2 lines of standard chemotherapy. For liver disease, evidence of irreversible liver damage, a serum albumin of less than 3, and an INR of greater than 1.3, and a whole host of potential comorbidities, ascites, recurrent esophageal varices, etc., or evidence of irreversible liver damage and a MELD score of greater than 19. So as you hear those criteria, as you think about these patients, I think we can agree that they are very, very sick, that this is a very acutely ill population that is defined in the SB 1004 policy. Next slide, please. And the other thing that you'll note as you sort of consider the eligibility criteria is that there's different sources for the type of information that you need to make an assessment about eligibility. So some of the criteria are documented in claims or administrative data. So information about primary and secondary diagnoses, use of health services like hospital admissions or ED visits. Prior hospice enrollment could be used as a proxy for evidence of advanced disease. Information from pharmaceutical claims database, for delivery of chemotherapy, for example, could be picked up there along with diagnosis and procedure codes, or orders for home O2. Some of the criteria might be documented in an EHR, and some systems, some health systems and medical groups actually have EHRs that capture things like, and then can extract things like lab values and biomarkers, many of which were described in the eligibility criteria, detailed information about stage of illness. Many EHRs have separate sections where advanced care planning documents have been where the presence of those is noted, where goals of care discussions are noted, where functional status information is available. And if you have access to a really good EHR, you could get at some of those, in particular disease-specific criteria that you could then marry with your claims data to begin to get a sense of which patients are eligible. Excuse me. Even so, even if you have the world's best EHR and you have access to comprehensive and accurate claims data, some of the criteria that are listed can only be reported by providers or patients and caregivers or gathered by manual chart review, which I would hope that none of you would take on as a task. So all of those items that we listed as possibly available in an EHR, a lot of those just wouldn't be available unless you call and ask or have somebody look up the patient's chart if you happen to, say, be in a health plan where you don't have access to a detailed medical record, or if you're working in a system that doesn't have that comprehensive of an EHR. Any information about patient preferences, care plans, willingness to attempt in-home therapy and participate in advanced care planning, it is almost certain that you would not be able to mine data that would give you information on those elements of eligibility. So the take-home message is that it's just not practical, and it's probably not possible to consider all eligibility criteria when estimating the number of patients who might be eligible for SB 1004 palliative care. So you're going to be using proxy data elements, you're going to be developing, you're going to be identifying a population of patients which is very likely larger than the number of individuals who will ultimately qualify for services. Next slide, please. So let's just look at a few specific examples of what's in the eligibility criteria that could be pulled from claims data. So from the general criteria, you can certainly look for use of the hospital or the emergency department. Basic utilization data is available to just about everyone. As I mentioned, you could probably also look for individuals who have enrolled in and graduated from hospice as evidence of advanced irreversible illness. For the disease-specific criteria for CHF, you can certainly look for hospital admissions where the primary diagnosis was heart failure. You can also use claims data to get at the presence of significant comorbidities. For COPD, many health plans would be able to access information about authorizations or billings that would point to patients receiving home O2 therapy. For advanced cancer, primary and secondary diagnosis codes can get at the presence of metastatic disease, lymphoma, and leukemia, and you can also use diagnosis procedure codes as well as other claims data to document delivery of standard chemotherapy. And for liver disease, all of these comorbid conditions are possible to find evidence of through primary and secondary diagnosis codes associated with clinic visits, any number of ambulatory services, as well as hospital admissions. Next slide, please. So what might be documented and possible to extract from a really good EHR? Well, some EHRs have in a predictable, dedicated place information about functional status. They have information about where they document hospice education and eligibility discussions and or goals of care discussions, and some are even able to use natural language processing to pick up descriptions of say, a hospice conversation that appears in the text portion of a physician's note. So if you have access to information like that, you can certainly use it to get at the number of eligible patients. In terms of disease-specific criteria, information that would likely be in an EHR, so just a range of the lab values and biomarkers, everything from New York Heart Association classification to EFs to O2 requirements, functional status as measured by Karnofsky, and then particular lab values applying to liver disease. And some also have MELD score. Next slide, please. And what items in those eligibility criteria are very likely unavailable to you as you're generating your estimate of potentially eligible patients? So you're probably not going to find information that describes that a patient is not eligible for or has declined hospice enrollment. You probably are not going to find information that's going to tell you, independent of a dedicated analytic software program that your plan may have or your system may have. There wouldn't be anywhere in a claims file where you could find documentation that death within a year would not be unexpected. You won't be able to find if a patient has received all patient-desired medical therapy, and you certainly wouldn't find in standard mineable data information that documents that a patient received in home or participate in care planning. And then for CHF, the issue of care planning, of no further interventions planned, that also is something you probably are not going to be able to get at. Next slide, please. And one thing I wanted to point out, given the fact that you probably are going to identify in your eligibility estimate more patients than actually would be technically eligible because there's going to be some values that you're going to be unable to access, it is also the case that there are a lot of other factors apart from just pure eligibility that impact enrollment, how many patients your organization is likely going to be serving. So referring providers need to know about and refer to the palliative care program. Patients need to be willing and able to accept services. Eligibility needs to be recognized early enough to allow for a referral to palliative care. So if folks are only figuring out that this patient is eligible in the last 2 weeks of life, there's really not an opportunity to make the referral or for the team to begin seeing the patient. And then palliative care providers need to have the capacity to take on new patients. And all of those 4 factors can really reduce the number of patients who are actually receiving services as a subset of the number of patients who are technically eligible. So the take-home message here is that it is likely that only a subset of the individuals that you're able to identify with claims data, plus or minus EHR data, plus or minus chart review or interviews with providers or patients to try to figure out, well, how many eligible people are there. In fact, the number who will be referred, who will be eligible and referred and accept services will be smaller than the number that you're able to identify and incorporate into an estimate. And that's just, really important to know. If you go through and make an estimate and you feel like you've done a credible job of identifying patients who have advanced disease and have the appropriate diagnoses, and you have some assurance that they're interested in this type of care, so they probably have agreed to home-based management, it's important to know that that is probably not going to come anywhere close to the number of patients that you actually serve. So just use caution when thinking about your expected volume based on these types of estimates. You can get close, but you're not going to get you're not going to be able to be precise. Next slide, please. All right. So given all of those caveats and challenges about what you need to go through to try to estimate the number of potentially eligible patients, there's sort of 2 big categories of methods that you can use for making these types of estimates. There's a prospective method. So you determine the number of members or patients with qualifying diagnoses and appropriate utilization history, and then you supplement that information with available indicators of advanced disease. So really the question that you're asking in the prospective method is, based on current membership, how many patients with qualifying diagnoses appear to have advanced disease? And that's how you would define that's what you would, that would be the heart of your estimate of the number of potentially eligible patients. And then there's also a retrospective method where you identify a population of decedents with the qualifying diagnoses, and you look back from the date of death to appreciate how these individuals used healthcare services in the final year of life, the timing of their presentation in relation to death, the costs in the final year of life. So you can generate quite a few metrics to describe what was their healthcare interaction experience like, and you can be pretty confident that they had advanced disease because it's a decedent population. So the way that you would sort of reframe this as a question if you're doing a retrospective assessment is, based on recent historical experience, how many patients likely would have qualified for SB 1004 palliative care, and how did those patients utilize healthcare services? So you can look at your current enrollment and then make an estimate based on that using a prospective method, or you can identify a population of decedents and make your estimate based on a retrospective analysis. Next slide, please. So prospective identification. I'm not going to get into this too much today. I think that this is a method that's probably fairly familiar to most of the individuals on the phone who are affiliated with health plans. But in a nutshell, what you would do is you would mine the claims data to identify members with qualifying diagnoses and some defined minimum amount of utilization within the past year or two. So it could be must have at least one hospitalization, or must have at least 2 ambulatory encounters, or must have at least 1 ED visit and 1 ambulatory encounter. Something that tells you that this patient has in the past year or continues to be one of your patients. You would then use ICD-10 or HCC codes to identify the disease group that these patients belong to from among the 4 that are SB 1004 eligible. And then just a note here, many patients have multiple conditions, so you can see COPD and heart failure together. You can see liver disease and cancer together. So when that comes up, it's not an if, it's a when. You need to make a determination and assign them to a primary disease group, not because that's going to affect down the road when you're actually implementing the program, not that that's going to affect eligibility per se, but you don't want to double count, and you also want to segregate patients according to disease group so they're not sort of competing with each other to be in that sort of upper echelon of most advanced disease, most complex, highest utilizers that you would identify as being, yeah, that's probably our SB 1004 population. So you identify this sort of big group of individuals that have a minimum amount of service utilization, that have the qualifying diseases, and then you really need then to narrow it down to individuals with advanced disease within each disease category. And there's a number of ways of doing that. You can generate risk scores that point to the probability of hospitalization or death using analytic software that's already available within your plans or group if you have such tools. So Optum has tools, there's many others that are out there that you all probably use already to do risk stratification. You can also, in addition, or incorporate authorization and utilization data in, so information about admissions or ED visits or chemotherapy administration, pharmaceutical claims for certain medications, claims for home equipment such as a hospital bed or O2 or other DME, recent disenrollment from hospice. So essentially indicators tailored to each disease group as appropriate that would tell you that this is not just a heart failure patient. This is a heart failure patient that has advanced disease. And I can't stress enough how important that is. I think the last time I heard about this, I'm not exactly sure on the statistic, but I believe it was something like the 5-year mortality rate for heart failure was something like 50%. And so if you're purely basing your estimate on presence of a primary diagnosis that corresponds to one of the identified conditions, you are at great risk for identifying way, way, way more individuals than would qualify according to the eligibility criteria in SB 1004 policy statements, which really do define a very, very sick population. So word to the wise there, diagnosis codes alone won't do it for you. Okay, next slide. So method number 2, a retrospective decedent analysis. So in a nutshell, this method is you identify a population of decedents with the qualifying diagnosis. And so how do you find out who died? How do you determine that portion of, how do you get that data point? Well, you can certainly, if you're a health system, look to see how many patients died in your hospital or your ED or other types of facilities, or you can access an external file, some information that identifies patients who died outside of the hospital, and we'll talk about one such source in a minute. You would then want to exclude trauma patients, and here it's not because patients with heart failure or cancer don't get in car accidents or get gunshot wounds or whatever. Those events wouldn't be associated with their palliative care needs arising from their primary diagnosis, and also their utilization information, quite frankly, is just so skewed because of those big catastrophic events that create quite a bit of cost that they're going to skew your findings. So you identify the population of decedents, you marry information from your health system or your medical group or your health plan with some information that tells you date of death for an identifiable number of individuals. And then once you marry those two things together and you identify your decedent population, you can analyze the 12 to 24 months of utilization preceding death. And that will give you information on the number of decedents with qualifying diagnoses, what their utilization and costs were like for different types of services over time. You can estimate when in relation to death they likely became eligible for SB 1004 palliative care. So was it beginning in month 8 prior to death that they started accessing the hospital and the ED to manage their progressive illness, or was that happening closer to month 6 in the population that you're serving? And you can also use that data set to generate some quality of care information. Next slide, please. So one of the advantages of doing the retrospective decedent analysis is that because you know when a patient died and you can know for sure when they interacted with healthcare system, in which settings, and how much it cost, and what that said about the quality of service and the access they had to things like palliative care. There's quite a few really useful metrics that you can generate at the same time that you're just estimating the pure number of individuals who might qualify. You can look at the frequency and duration and intensity of hospitalizations, total and trended over time in relation to date of death. You can look at the frequency and timing of ED visits. You can look at the frequency of 30-day readmissions. You can look at in-hospital and 30-day deaths. You can also consider use of ambulatory services like clinic visits and other home-based services that you may have an interest in, for example, because you're wondering where are these patients going before they start showing up at the hospital. And yeah, I want to reach out to those providers to generate referrals and also to give a lot of education about palliative care. You can use the data set to generate information about the use and timing of specialty palliative care available in your hospitals, affiliated hospitals or network hospitals, or even if you have an existing palliative care service. Use and timing of hospice, if those data are available, and they are not always available. And then also information about the cost of care, both total in, say, the last year of life and trended over time in relation to date of death. Next slide, please. So, but you remember that sort of job one in trying to do the retrospective analysis for estimating number of eligible patients is to find out when a whole bunch of the people who were cared for by your network or who are members of your health plan, when did they die? And that can be really hard information to gather. We do have a publicly available source in the state of California. The Department of Public Health maintains what they call the public use death files, and I've given you the URL there where you can pop onto their webpage to learn a little more about that information. And you can also access from this page, you'll see it in the bottom towards the right-hand side of your screen, where you can fill out an application to actually acquire that data for your organization. Next slide, please. So the information in the file is actually pretty limited. It gives you information on the last name, first name, and middle name of the decedent, information about sex, their date of birth, their place of birth, their place of death. So if you want to narrow in by limit your search to individuals who died in a particular county or city, and the date of death, and a data item that I've never seen anybody else collect, which is father's last name. So a unique identifier such as Social Security is not included in this file, but I know several groups that have actually used it successfully to match to claims data or utilization data from a health system or a medical group simply by matching on the three name fields, the sex, and the date of birth. There's a few different methods for doing this, things that you might want to keep in mind if you have some particular ethnic populations that are being cared for by your health plan. There's some naming conventions that you'll want to keep in mind as you're doing your match. But this works perfectly well, and you can match up the data in this file to the data in your claims system or your administrative database to see where there is overlap, and that would be how you define your population of decedents. Next slide, please. the data you need at an affordable price. It's actually pretty good data that's pretty easy to get. It can be a little bumpy in the administrative process. It can be a little bit of a delay because our friends at the state are not overly staffed, and so it can take them a little while to get to the requests. But there's actually a few advantages to the file as compared to, say, Social Security death index data or data from CMS. There's a pretty minimal lag between the time, the date of death and when the files are updated, so you're not going to have to wait to get a sample that is, say, 2 years old. There's flexible access options. You can purchase batch files for a pretty small amount of money for the first year, and then a very small amount of money for subsequent years. And they also have created the option to contract with them for quarterly or monthly delivery. And again, there have very often been some administrative bumps along the way as you try to get these things set up. But once it's in place and you have the data, it really opens up a whole universe of analytics that you would not have had access to before. There is an application that you have to complete, but it's pretty darn simple. You just make a statement about how you will use the data, to make assessments about the quality of care delivered to seriously ill individuals, or to estimate the number of SB 1004 eligible patients would be good statements of how you intend to use the data. You have to describe your data security measures, which all of you as healthcare organizations, I'm sure, have very robust data security systems, and you do have to have the application notarized. But compared to just about any other application I've seen, this is short and to the point and easy to complete. Next slide, please. So I wanted to go into a little more detail about how we went about doing a retrospective analysis, a decedent analysis, working with data from the San Francisco Health Network. Ann Kinderman and Heather Harris there, working with their clinical and administrative leaders, went through the steps of saying, yeah, we want to gather these data to get information not only about SB 1004 eligibility, but also about end-of-life utilization patterns. Generally, the data that we compiled get at much more than just the SB 1004 eligible population, but this is a nice example of some of the things that you would be able to do if you undertook a decedent analysis within your organization. So we identified a decedent population by combining the California Public Use Death Data File with utilization data from the San Francisco Health Network. A San Francisco Health Network patient was defined as somebody who had 2+ ambulatory encounters, or 1+ one hospitalization and 1 ambulatory encounter at least in the final 2 years of life. And then we took that population, saw from among those folks where we found a match in the decedent file, and gathered for this group information describing inpatient admissions, ED visits, clinic visits, use of ambulatory services like dialysis, nursing home utilization among individuals known to have died between July of 2013 and June of 2015. And then for the qualifying patients, we assembled data describing all of those clinical services that I just mentioned for the entirety of 2 years preceding death. So for each patient, if a patient died in January of 2015, we got their data going back through December of 2013. Next slide, please. We use primary and secondary diagnosis codes and procedure codes to determine which disease group patients would be put into. And for patients with multiple qualifying conditions, so cancer and end-stage liver disease, or CHF and COPD, we assign those patients to a single disease group based on the condition that was associated with the highest amount of charges. So if you had $40,000 of charges for your CHF and only $3,000 for your COPD, you got called a CHF patient. For individuals with more than one primary payer, and there were plenty of those, you were assigned to the payer associated with the highest charges. So if most of your charges were associated with, say, a Medicare as a primary payer, but you had a few pop up that were associated with Medi-Cal, you would be assigned as a Medicare primary payer. Now, there were some limitations to the data, and I just wanted to point this out because all of us in all of this type of work, we do the best we can with what's available. And there were a couple of data items that we would have loved to have which just weren't available from the San Francisco Health Network. So they do not specify in a reliable way the number of ICU days associated with inpatient admissions. So we couldn't look at a very common metric of proportion of patients who had an ICU stay in the final 30 days of life. That would have been nice to know, but we couldn't access it, nor did they have information describing use of hospice. And also, they don't have a cost accounting system. And I just mentioned that because I think in a lot of safety net systems or in very small health plans, you may not have as robust of a IT system as you want. You just make do. And what we did was we used a method that had been previously endorsed by the CFO to convert charges into calculated or model the direct costs to the network associated with each bit of utilization. Next slide, please. So what is it that we were able to cull from these data that speak to the issue of how many eligible SB 1004 patients are likely cared for by the network in a typical year? What were their utilization patterns like? Well, number one is sort of that volume issue. Now, because we're looking at a decedent population and everybody died, we didn't have to get into too much detail about all of those secondary indicators of advanced disease that you would need to use to consider if you're doing a prospective analysis. And what we found is that in this 2-year data set amongst Medi-Cal beneficiaries, so Medi-Cal, not dually eligible, just Medi-Cal as a primary payer, there were 747 patients in the data set, 552 of whom, so 74%, had SB 1004 qualifying diagnoses. And if you look at that, just sort of that number that you can make a gross estimate, there's going to be something like 276, 275 patients a year seen by the health network who would qualify for SB 1004 palliative care. In terms of distribution of the particular diseases, the largest group was cancer by a lot, so 45% of the population annualized. The next largest group was end-stage liver disease at 29%, followed by COPD at followed by CHF at 19%, and COPD at 7%. Next slide, please. Another question that you would have if you're looking to understand the SB 1004 eligible population and then the probability that you're going to be able to identify them and refer them successfully to a palliative care program, you might frame that question as, by what point in the last year of life are SB 1004 patients becoming clinically active? And so this can work in a couple ways. You can have worries that patients present very, very late in the disease course and there wouldn't be time to identify them as being eligible and get them hooked up with a service and have that service have enough time to actually do some good for them. The other fear, of course, would be that all of these patients are heavily using healthcare services a year or 18 months prior to death, and that even though they're technically eligible, you might be paying for a fairly expensive intervention, home-based palliative care, for a long, long period of time. So what this graphic shows you is the cumulative proportion of the entire SB 1004, so all 4 disease groups of that entire population that has become clinically active by month preceding death. And so clinically active is defined as they're presenting to the clinics, they have charges for ED visits or hospitalization, they're actually using services provided by the network. And the numbers in the x-axis represent the months preceding death. So 12 is 12 months preceding death, 11 is 11 months preceding death, and so on down to 3 months, 2 months, 1 month preceding death. And what you'll see is that in this population, more than a third of them, 37%, were already using services 12 months prior to death. And that jumps up to 46%, 11 months prior to death, 52%, 10 months prior to death, and so on. So it's there's sort of a mixed message here. On the one hand, by the time you get to 6 months preceding death, 68% of these patients are utilizing services within the health network, and that says they're going to clinic, they're going to the emergency department, they're being admitted. People should be able to recognize that they might need and be qualified for SB 1004 palliative care, so that bodes well. And then there is this other group of patients, a full 22%, who did not begin using services until 3 months or sooner before death. So it was less than 3 months of total engagement with the health network for 22% of this population. And so it's worth thinking about, this is one of the reasons why it's really important to maintain hospital-based palliative care programs. And it also potentially points to an opportunity to figure out, are there other ways of identifying these patients sooner, even if they are presenting to the health system very late. Next slide, please. How often are SB 1004 patients admitted to the hospital in the final year of life and in the final 6 months of life? So this is one way of thinking about, well, how much of the utilization that's currently happening, is there actually an opportunity to modify it? How intensely are these folks engaging with the health system? So for this population, most of these folks are, on average, these folks were admitted 3 times in the course of the final year of life, and some patients were admitted very, very frequently. So the max number in this data set was 28 times within the final year of life. And you'll note that the bulk of that utilization occurred in the final 6 months of life, which is not at all unusual to see in this population. Next slide, please. So what are the average costs per patient in the last year of life, in the last 6 months of life? And you'll see that, and these are calculated or modeled direct costs from the perspective of the health system. I am sure that the costs, if you assess this from the payer perspective, might be quite higher if they were paying for services instead of just incurring the cost of delivering care. But in the final year of life, the average per patient cost was more than $56,000. The median was $34,000, and you'll see from the max values there that there were some pretty extreme outliers. And you'll also note that, not surprising given the extent to which inpatient admissions drive cost of care, that the bulk of those expenses were incurred in the final 6 months of life when the bulk of the admissions occurred. So a full 72% of the expenditures in the final year of life occurred in the final 6 months of life. When thinking of it in terms of the mean value, 64% if you're thinking of it in terms of the median value. Next slide, please. So here's a metric that can sort of explain why those cost values appear as they do. You could ask, what is the pattern for hospital admissions in the last year of life, given the role that hospital admissions play in driving total cost of care? And what you see here is, again, on the x-axis, those months preceding death, and on the y-axis, that's just a pure count. So in an annualized, just how many hospital admissions are happening for this SB 1004 population, which is approximately 276 patients by month preceding death. And what you see is that it's fairly steady up through month 4, and then it takes a sharp turn upwards. And that sort of hockey stick pattern of elevated in, frequency and cost and intensity of care in the final period of life is exactly the use pattern that it's been shown to be modifiable if you're able to deliver clinic or home-based palliative care as a supplement to inpatient care, which may be delivered very late. And excuse me, I'm showing you just counts here as opposed to an average value per patient, because it gives you an idea that there's quite a bit of utilization to work with, where you don't have to avoid a hospitalization for every patient in order to put a big dent into these big numbers of admissions that this population is having. Next slide, please. And then, not surprisingly at all, given what we just saw in terms of the pattern of hospitalizations, the costs have a similar cost, have a similar curve as you go from 12 months down to 1 month preceding death, where costs are per patient costs are fairly stable up through month 5, and then start to rise, and then there's a dramatic spike in the final month prior to death when long hospitalizations, and even for some patients, multiple hospitalizations occur. Next slide, please. So how many SB 1004 patients are currently getting palliative care, and at what point in the disease course? And this was an important question for the San Francisco Health Network, because they have a well-established and very effective inpatient palliative care service, which has been very successful in seeing a large proportion of the individuals who are admitted to their hospital. They see almost half of the patients who die in their hospital. But what type of penetration are they having for folks over time, given that they're only able to touch patients who are admitted to the hospital, which can tend to happen very late? So what we saw from this data set is that 69% of the patients were never referred to specialty palliative care. And that might be because a very small proportion of them were never admitted to the hospital, or they just weren't referred when they were admitted. 25% of them had their first palliative care contact in the final 90 days of life, which is really such a limited time frame to take care of all of the important tasks that need to happen as somebody's approaching death. And only 6% of this population had their first palliative care contact more than 90 days before death. And I would say that what this shows me, given the penetration and the experience of the inpatient, of the hospital-based palliative care team at Zuckerberg San Francisco General, is that this just truly reflects the limitation of only being functioning in the hospital. And this just points so clearly to the need for clinic-based and home-based services to supplement the care that's delivered in the hospital setting. If you look at the interval between first palliative care contact and death, the mean was 60 days, the median was 26.5 days, so less than a month, and the range was quite wide, so 0 to 352 days. Again, clear indicator that there is a need for clinic or home-based palliative care service delivery in this network, the type of service that's described in SB 1004 palliative care. Next slide, please. So this final slide is really just sort of a graphic that shows, given what we talked about before, the proportion of SB 1004 eligible patients who become clinically active in relation to month of death. So by month 6, 68% of this population are utilizing healthcare services in the clinics or in the ED or in the hospital. Even so, 68% of this population, which has chronic, progressive, serious illnesses where death should not have been a surprise, only 2% of those patients were referred to specialty palliative care. So this points to an abundant opportunity to incorporate additional specialty palliative care into the health network. Next slide, please. We're sort of running low on time. I guess I was speaking a little slowly today, so I'm just going to cruise through some of the take-home points and I'll let you review these on your own. So just to review very quickly, for the prospective method for estimating the number of eligible patients, it's beneficial in that you don't need to go out and grab additional data beyond what's available within your organization. It's a terrific method to use if you're a health plan that has access to analytic software that you can use to risk stratify patients. It's a great option if you're a health system or a medical group that has access to some robust data from a EHR. It requires some effort to do, but I believe it's the easier of the two methods. The cons is to really watch out for the fact that you will likely grossly overestimate the number of eligible patients if you only consider primary diagnosis codes when defining your eligible population. It might be hard to get at some of the acuity eligibility diagnosis data depending on the type of systems that your organization has access to. And it's a lot harder to do an assessment of, say, utilization patterns when you use a prospective method because you don't have any clarity on what point in time that assessment is being made. Are you 2 years out from death, 6 months out from death? There's just no way to know. Next slide, please. So the retrospective method, as you might be able to tell from the amount of information that I shared with you, I'm a big fan of the retrospective decedent analysis. There's no question that these patients would have qualified. They were all sick enough to die. And you're looking at the utilization patterns amongst the population of decedents. You're also able to generate a lot of other useful information, metrics that speak to the timing of accessing health care services, some information about the quality of care. The big con is that you need to go out and grab the death data, and it can be time intensive to use. Next slide, please. So by way of wrap-up, I just want to mention the in-person workshops that are coming up in August. Basically, the objectives for the workshop is really just a more detailed and interactive version of what we talked about today. We'll talk about strategies for identifying the number of potentially eligible patients, what your experience has been with doing that. We'll review some methods. We'll get deeper into specifics of particular maneuvers that might be useful and sort of teasing out the advanced illness subset of a larger population of patients with a specific disease. And there'll also be some time for you to think about local data sources and who specifically within your organization might undertake this work. Next slide, please. In terms of how the workshop will be run, our approach is really going to be participatory. We want to give you opportunities to share strategies and experiences. Many of you are very practiced in doing this type of work, and you may have tried things that worked well or didn't work, and I think there's an opportunity for us all to learn from each other. The workshops are designed really for the health plans and for the delegated groups that are responsible for ensuring access to palliative care. This really wasn't a topic that was aimed at provider organizations, though many expressed interest in it. We appreciate that, and there'll be future topics that are aimed at your needs. And we thought it was really important for both a member of the data team and a member of the clinical or programmatic team to come, because you have unique perspectives, and together you guys could come up with the best strategies for tackling the task of estimating population size. We'll be distributing tools and resources at the workshop, so code lists, process outlines for different analyses, useful metrics that you might consider generating in addition to planning worksheets. We have 3 remaining workshops that have availability. The August 15th Southern California session is full. We have a session on August 17th in Northern California. There's 1 remaining slot open for that. If we need to, we'll open another session on the 24th in Northern California, and there are still openings in the Southern California session that's being offered on August 29th. Next slide, please. So I need to apologize to you all. This wound up taking about 10 minutes longer than I thought it would, and so I've really eaten into the question section section. If we have a couple minutes, and I'm happy to take any questions if they have come through. And before we get into that, I just want to acknowledge some colleagues who shared their knowledge and or data to help inform this presentation. So Ann Kinderman and Heather Harris from Zuckerberg San Francisco General, my friend and colleague Brian Castle from Virginia Commonwealth University, and Tori Shields from Blue Shield of California. And there's some information there at the bottom of the page. If you have questions about the Technical Assistance Series, upcoming webinars or workshops, you can get in touch with Glenda. If you have questions about SB 1004 policy, we refer you to their website. And with that, if there is one, I believe we would have time for maybe one question.
Thanks so much, Kathleen. This is Kate Myers with the California Healthcare Foundation. Thank you, everyone, for joining. What a wonderful presentation. And we do have 2 questions that have come in during your presentation. And I'm happy to keep the line open for maybe an extra 5 minutes or so if others have questions they want to type in. So we can maybe get to a few of these. So just quickly, the ones that have come in so far. One is, do you have a recommended list of ICD-10 codes for the 4 disease-specific eligibility groups?
Why, yes, I do. And so that's one of the handouts that we'll be distributing at the workshop. And then I should mention also that all of the materials that we're preparing for the workshops will also then be made available on CHCF's SB 1004 resource page, and that would happen within a couple weeks of the closeout of the final workshop for a particular topic. So yes, we have that. And actually, if you don't want to wait that long, if you want to if you email Glenda, Glenda, if I could ask you to pass that on to me, I'm happy to just email that to you. That's a long time to wait for a pretty specific item.
Thank you. And then actually the other question I can quickly answer, you've already addressed at different points. There was someone asking whether we'll be sending the slides out, and yes, both the slides and the recording of the webinar will be distributed and will be available on the CHCF website. With that, we'll give another couple moments. If there are any other questions, please go ahead and type them in to the question box or the chat box, whichever you prefer. Well, seeing no other questions at this point, I think we'll go ahead and close right about on the hour. And again, if people have questions they think of after the fact, please convey those through Glenda Paha, and we will get them to Kathleen or to Anne, depending on the content. So thank you again, Kathleen, for your wonderful overview. And thank you, everyone, for attending today. We look forward to those who are participating in the workshops to seeing you next month. Thanks so much.